we're going to move on to one of my favorite parts of primary care, which is screening.
I guess I have a random question.
Oh, yeah, yes.
Because now we're being referred to as like consultants.
Yes.
Do they know what our background is, like our schooling background is?
So, and I'll show you a script. The way Zeke introduced it is just one way. Typically what you can say too is I'm a behavioral health consultant, I'm a health psychologist by training, is what you can add to that. You'll see that in the video too. I'm a counselor in training. I am a social work, we have a social work, I'm a social work intern. Whatever you may be, introduce it as a behavioral health consultant, but let them know what your background is. Because many different people can be BHCs. There's clinics that hire nurses to do BHC work. So it's many different disciplines can do this too. Good question. So screening. So I'm going to walk you through what happens in a visit before we get to the actual nitty-gritty pieces of a visit. So one of the things that is really important for primary care is screening. We need to know what's going on besides how are you feeling today. That's a great way to build some rapport, but it's not going to give you the outcomes in terms of, well, how are you measuring change? We need to know if what you're doing is effective or not. And so my question for you all is, are you using any outcomes tools in your prac sites? And if you are, what do you use? Or other sites you've worked in, what screening tools, outcome tools do you use? How do you measure change? Besides, how are you feeling today? That's not good enough. How else are you measuring change with your patients?
Well, in the Sarabi Center, they use the SRS and ORS.
Yes.
And so they'll graph that, and you can see by the graph how the changes are from session to session.
Got it. Perfect. You show that to the patients so they can also see their change? Some people are...
Yeah, so we don't go in with a client file, and that is put in the client file, but what they do see is they'll fill out that form.
Okay.
And they'll be able to, they kind of consciously know that they're improving or not improving, because depending on the client, they'll make a comment to it. But
Okay.
no, we don't practice showing it to them.
So they don't see it. They don't get to see the change in scores.
Right.
Okay.
But it is used as can be used as a tool if you
Yes.
so choose to say, I'm noticing that you're a little bit lower this week
Yes.
than last week, or I'm noticing you're higher. Let's talk about what those changes are.
Yes.
So you can bring it to the client's
Attention.
Yes. You can use client when you're talking about your setting. Yes. Just
Okay,
in primary
we're gonna
care,
use-
this is where the skill comes in, switching between the two. Somebody else had a hand. Yes, ma'am. Okay. 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 So I'll talk to you guys about that. It's really powerful for them to physically see their changes. So talking about it's one thing, but to map it and show it to them from visit 1, 2 to 20, there's something about it that the research has captured that it's just more meaningful if they could see it graphed for them. So sometimes when I'm in clinics that don't even have an EMR to track it, I'll just build it in an Excel sheet and just show them the graphs. I want you to see that, well, what was going on in visit 2? What happened? Something happened in my at work. So it really helps in terms of helping them build insight too to what's going on, especially folks who really don't have a lot of insight into what's going on. So the ORT, what else are you familiar, or what are we familiar with? Maybe you haven't used it at a site, but what are some behavioral screening tools that maybe you've heard other sites using, or you've read in a class? What do you know?
At least in my background, we would go through their medical history and see if there was anything changed, first of all, or if anything was resolved.
Okay.
And then if it was, say, a study pertaining to depression, we would give them like a CSSRS.
Okay.
To assess for any types of ideation or anything like that.
Got it.
And then we do all the other standard stuff, like vitals,
BMI and all that jazz.
urine units.
Very good. Okay. What else? I thought I saw like a half hand go up, and I quickly put it back down. Okay, so this will be good. This will be hopefully new information for you. So we'll skip that. We'll get to that a little bit. So I've kind of already hit on this. I think we've have the take home that primary care is the de facto mental health system. Now, has been, and probably will be for a very long time. So why screen in primary care? Because PCPs don't ask these questions. So that's why for the longest time, conditions have gone underdetected, undertreated, because we're not asking. If you ask,
Right.
they will tell you. They'll tell you. Oh yeah, I've been dealing with this for like 20 years. I have PCPs say that they've been seeing patients for a very long time, 15, 20 years, and they just find out about substance use that's been going on for 10 years because they didn't ask. They never did a UA. They never inquired about it. So these are some common issues, some common things that we screen for. Of course, substance use, depression and anxiety, that's low-hanging fruit. Depression is the #1 condition in the world, and not just in primary care, just anything, any setting, across the board. So we've definitely got to screen for that because that's really simple to treat if you think about it. Depression's a treatable condition, yet we don't do a great job of detecting it, then treating it. We wait too long, and then it's a little bit harder once it's been around for a long time. Developmental screening for children, of course, and then quality of life is a big one. It's really helpful for planning what you're going to do, and then evaluating if what you do is working or not working. So again, behavioral health gets a bad rap, for they have for a long time, because they don't track outcomes on what they're doing. PCPs, it's a little bit easier for them because they can just go get a blood test and come back and there it is, there's the measure. Everything you do is somewhat subjective, essentially. So it's a little bit harder, but still doable and necessary, especially as we're moving in terms of how we pay for primary care. I won't get into that today, but we're moving away from this fee-for-service. I see you for this many minutes, I get reimbursed for this much time, to value-based payments, where you're going to be reimbursed for how well you treat patients. They're already doing this for medical providers. In behavioral health, we're next. They're coming for us, so we need to prove what we're doing is working or not. So if you're not tracking it, you're going to get left out of the pot. So Dr. Trayvall wants you all to advocate for yourself. This is one way to do that. You need to track what you're doing so you show your worth, that what you do is vital for patient care. So we'll talk about this today. And then, of course, screening is not a diagnosis. It's just to give you an idea of what's going on. And then you, with your expertise, can come in, offer some follow-up questions to see, is this person really depressed, or did someone just totally cut them off in the parking lot and they're just pissed? They're pissed today. And they've circled all 3s on the questionnaire because they're mad. Or they've been waiting for an hour and a half for their visit and they're pissed off and they're just like, all 3s. So it's a way to at least get your foot in the door to have a conversation about what's going on for them. So we're going to get into a little bit of psychometrics. I promise I won't bore you with a lot of psychometrics. Do you guys take like a measurements class, like research design?
Mm-hmm.
Yes, have you taken it yet? Okay, so hopefully this is a small review for you. Or dusting the cobwebs off, if it's like, it's way back there. So sensitivity and specificity are 2 big areas in psychometrics that we look at for screening tools. So PCPs are really, we train them on identifying this for them. So they're gonna expect you to know what sensitivity and specificity mean. So sensitivity is just saying, does the tool identify the people with the condition? How well does it do it or not? For the PHQ-9, raise your hand if you've heard of the PHQ-9. Yes, okay, so that is kind of the gold standard for measuring depression in medical settings. It's what everybody, even in some mental health settings, they use that too. So how well does the PHQ-9 actually identify people who really do have major depression and screen out the ones who actually don't have it? It actually does a really good job of doing that. This is specificity. How well does it specify the folks who don't have the condition? So how well does it rule out people that don't have major depression? So typically for screening tools, you like them to be at least 80% and above. That's really good if they can do that. If it's below 80%, I think I wouldn't use that tool. Gonna be hard to defend if you ever subpoenaed in court at any given time. So make sure it's at least 80%. That's usually the rule of thumb, 80% and above. How you find that out, you can use your friend Google Scholar and Google sensitivity of the PHQ-9. It'll pop up for you. Sensitivity of the GAD-7. It'll pop up for you. Specificity of it. The PHQ-9, by the way, is like 88% and like 90%. It's pretty good. There's still, 12% that it doesn't do well with, but that's pretty good for a 9-question screening tool to rule in or rule out the possibility of depression. And then, of course, using the screens as they were designed. So if you're interested if a person is experiencing depression symptoms or not, I wouldn't give them a GAD-7. Who knows what a GAD-7 measures? Anxiety. It's not totally different, similar symptoms, but really there's some obvious differences there. So make sure you're using what you're intending to measure. So if you want to know about depression, use a scale that measures depression. If you want to know about anxiety, use that. Makes sense to us, but you're going to be in settings with primary care providers that may not know this. So you can come in and say, actually, that tool is for children with anxiety, so we're not going to use this for this adult who you think is depressed. So let's give them another tool that's appropriate for them. Oh, goodness. So we're going to cover all these in the next 25 minutes. It's rapid fire. I promise. It's straightforward. I promise. So in your toolkit, you're going to have a lot of these screening tools. So as I'm going through them, sift through it and pull it out so you can take a look at it, especially since a lot of this is somewhat new for folks. So we're going to focus on depression and anxiety first. So you should have a PHQ-9. And as I killed all these trees, I apologize. Recycle them if you don't keep them. But flip through and pull out the PHQ-9. It should be a stapled piece of paper because it has the Edinburgh attached to it too. So once you find it, pull it out. Start browsing some of the questions so you can get familiar with it. A lot of your sites already use this as a built-in tool. They screen every patient that walks through the door with the PHQ-9. So know this well, because the majority of the sites you're going to, you'll get to know this screening tool very, very, very well. So the PHQ-9 is intended to measure depression, or depressive symptoms, I should say. There's a shorter version called the PHQ-2. So a lot of clinics use the PHQ-2 first. If someone screens positive on the PHQ-2, then they'll give them the 9. That's usually what most clinics do because it's quicker. The PHQ-2 is just the first 2 questions off the PHQ-9, so you can take a look at the first 2 questions. If someone says yes, or I should say a 1 or higher on the question 1 or 2, they automatically get the 9 after that. And so it can be used pretty much with ages 12 or up. You can use the PHQ-9. There is a PHQ-A, the PHQ for adolescents. It's essentially the same, just how they ask question 9, the question about suicidality. For the adolescent one, they use like quote-unquote hipper words to describe thoughts of wanting to kill themselves. But I find when I use this for 12, 13-year-olds, they get it. They've already been thinking about it anyway, so they know. They'll circle it. So there's also, I didn't add in the JDS. It's public domain, so if you Google it, you can find it in multiple languages. This scale is really useful because it's normed to older adults. So if you find you're working with older adults and you want to use this one, it's fine. You can use the PHQ-9 for older adults. It's okay. Just the JDS 15 has questions that are specific to older adults, and they're yes/no versus the Likert scale. So it's just a little different. But you do what you prefer, whatever works best. You also have the GAD-7 you want to grab that from your packet so you can take a look at that. This is a screening tool for anxiety. There also is, surprise, surprise, a GAD-2, which is also the first two questions of the GAD-7. The GAD-7 is really short. I just give patients the whole one because it's only 7 questions. It's pretty short. And so really the PhD and GAD-7 are used in primary care the most. All the screening tools that I'm showing you are normed for primary care. That's really important. They're normed for medical patients. You can have tests that are normed for psychiatric patients that you might use in an outpatient psychotherapy setting. But in primary care, our patients sometimes are a little different. And so you want to make sure any scale that you use that it's normed for the setting that you are in and the population that you are serving. So everything I'm showing you today are all normed for primary care, and they're normed in various languages, more than just English and Spanish, because we have lots of languages that are here in San Antonio. Now there's the HADS. I didn't add it on there. It's just another option of measuring anxiety in older adults. This is also public domain, so if you want to just see what it looks like, you can Google it and take a look and see how it words the questions compared to the GAD-7. So also there should be a key so you can see what the scores mean in terms of what's minimal, moderate to severe, severe. So it just gives you an idea of what to do. Again, just because someone scores a 21 on the GAD-7, circled all 3s, doesn't mean they have generalized anxiety disorder. That's where you come in to follow up with questions in terms of how long has this been going on, is this impairing your functioning or not, or are they just really stressed out? Is this a brand new mom? She's never had a baby before, and she's just stressed out. She hasn't slept for days. So, or months. So examine the say it again. Or 15 years. Or 15 years.
Or years.
Yes. So, and we'll teach you how to examine the patient's context to know when are these symptoms happening, so you know exactly, is this just more stress, or is this, whoa, we need to intervene for this person with something else. All right, we're moving on. So you've seen that, and you've seen that. So now, postpartum. You have it's stapled on the other side of the PHQ-9, I believe, the Edinburgh postnatal, depression scale. So it's a little bit different. You can kind of, if you can, I don't know how you can do this, look at the PHQ-9 questions and then look at the postnatal questions and see kind of how they word things a little bit differently. The questions are centered around the pregnancy, thoughts about, I think there's questions about thoughts about possibly wanting to harm the baby or not. So why wouldn't we want to use the PHQ-9 for women who are currently pregnant or in that peripartum period? What are some of the questions on there?
It's a whole different.
Okay, how so?
Well, when you're pregnant, you have extra hormones
Yeah.
and things like that that you don't normally have, and then depending on where you are in your gestation and where you are after birth, your body's in blackout.
Right. So what questions on the 9 may happen just as a result of pregnancy? Overeating. Yes, crying, fatigue. So trouble concentrating. That's just being pregnant. That's just part of it. So that's why we really discourage people using the 9, and they really need to use the EPDS because their questions are specific to women who are pregnant. So if you are at a site and you're asked to consult with a woman who is peripartum, be sure that they're using this and not sneaking in a PHQ-9 because the results are gonna be skewed just a little bit. And then this is another one. This is developed by the World Health Organization. It's called the Self-Reporting Questionnaire. It's just as good. It's just longer. That's the only thing. And so in primary care, if anything that you've noticed, we don't like things to be long. We like them short and succinct. So the EPDS is what you'll see used in practice the most. It's in English and Spanish and multiple languages. So that's what you'll see often. I just wanted to let you know that there is another one that's another one that you can use for in women's health. All right, substance use. So SBIRT. Who's heard of SBIRT? Who knows what the S and the BIRT stands for? So, that's a good guess. Substance. So SBIRT is, I want to call it a model of care. It's really an intervention for primary care to identify individuals who may be at risk for a substance use disorder. I can't remember when SBIRT was developed, but it's been around for a long, long time. It stands for Screening, Brief Intervention, and Referral to Treatment is what SBIRT stands for. There are, hi, that's Beverly. We'll point her out. And there are, if you travel around, you'll see clinics who have SBIRT models in their clinic. That's totally good. That's a good thing. SBIRT was initially created for primary care providers, for them, to encourage them to screen and treat or refer patients with substance use issues. What happened is they didn't realize that PCPs have 7 minutes, and they're not going to use MI to really encourage someone to go to treatment. So it kind of flopped using with PCPs. They don't really use it that much. But behaviorists picked it up, and so now a lot of settings who use SBIRT, the SBIRT interventionists are the behaviorists on the team. I've seen clinics use nurses, community health workers, so they can use a lot of different folks on how to do this. There we go. So you have this in your packet. If you want to look for the DAST and the audit, I think I made them
You did.
front to back. Perfect, okay. So the first one measures everything but alcohol use in the past 12 months. So there's just 10 yes/no questions to get an idea. Is it problematic use? Is it low risk? Is it moderate? Is it high risk? And depending on the risk level, depends on what you, as a provider, will do. If someone's low risk, that could just be as simple as, is it okay if I tell you about, what happens when we use substances, what happens to your body, then I'll give you some information about it, then they can make their own decision. So that's low risk. Moderate risk may be someone who maybe, have you trained in MI? You guys trained in motivational interviewing? Okay, maybe some. You will in the next class, you definitely will. And so SBIRT is framed on all motivational interviewing, that's all it is. And you would use a lot of MI to determine kind of if they're ambivalent, help you figure out what stage of change they're in to determine, would you like to meet with me to do some harm reduction to reduce your use of the substance? And you kind of create a plan with the patient to come up with to either stop use or reduce it to where it's at least in the low risk range if they don't want to quit. Because you have lots of patients who will come in and say, we had a gentleman, how many days ago was that, where he was like, no, I don't want to quit drinking. He just wanted to get down to a couple of beers, like 2 or 3 beers. So just figure out what their goal is and let's help them meet the goal as best we can with the patient. Then you have, there we go, the audit. So if you flip it over, this measures alcohol use over the past 12 months. Same risk categories, low, medium, and high are there for you. But essentially it's very similar to the DAST except for we're just looking at alcohol, measuring alcohol use instead. In your packet there should be a BH score sheet towards the back. That basically tells you what the scores mean for the main screening tools that you use. Then if you flip it to the second page, it breaks down the SBIRT score, the substance use on what to do depending on their score for the audit and the DAST. So you have a little cheat sheet there to help you as you're trying to figure out the patient scored a 15 on the audit. What does that mean? What does that mean if they score a 15 on the audit? Hazardous use. What would you do if it's hazardous? What does it say?
It says brief treatment if available or consider referral.
Yeah. So if you feel comfortable and willing to have supervision by your supervisor, so you can do the brief treatment in-house about using MI and using harm reduction to reduce their substance use, hopefully you all will do that. So you can get practice at doing this, because a lot of times, especially if you go to a rural site, there's not going to be a lot of places to refer the patients to, so you're going to be it. So it's better to do something brief than to do nothing at all. So you can do some brief visits with you first, and seeing them anywhere from 2 to 4 or 5 times. If you can get their substance use down, fantastic. If you feel that this is just not enough, you need partial hospitalization or an IOP program or something like that, working with them to see if they would be willing to go do something like that. So, very good. Any questions so far?
So, in these, screening tools, are you reading them the questions and marking the answers for them, or just kind of doing, like, we're giving it straight to them?
If they can read, if the patient can read, yeah, this is preferred. All of these, the method of giving it to them is have them do it. But if they can't read it, for whatever reason, then you can read it to them. About 90% of the time, 95% of the time, we're giving it to them. Every now and then someone has just vision is poor, or they can't read it, so we'll read it to them.
People always forget their glasses.
That's a great way.
When people can't
Yeah.
read, and
Yeah.
they just say they forget their glasses, at least in our population.
Yeah, absolutely.
Read it to them.
And that'll be something that I'll cover in the class in terms of health literacy and how to appropriately, rather than asking, can you read this? Some people do that, that's fine, but there are other ways to ask or figure out if a patient can actually read things with an understanding. So I'll cover that in the class in terms of how to do that, how to present it, and so how you can know what to do if they feel embarrassed or ashamed to bring it up, that they can't read it. Okay, gotta get closer.
But,
Oh,
I mean,
yes.
it's coming from like the counselor perspective of
Yes.
like, so let's say somebody scores really high on this, and
Mhm.
in doing so and talking to them, they're talking about their kids and their children are in that danger. Like the counselor in me is like, okay, what about reporting?
Yeah.
So how does that look in this situation?
It wouldn't change.
Okay.
Same PC. So things to understand with mandated reporters. I think behavioral health, like we beef it up way bigger than it needs to be. Any person who's a medical provider is a mandated reporter. So they have the same rules to us. So usually if something comes up and I feel the child is a danger, or if it's an older adult that I feel is being abused, I'll go to the PCP and say, who, you want to report it or me? Who has time to do it? You have maybe I have time, or sometimes I don't have time. And so I'll say, can you do this? So we'll problem solve, but somebody's got to do it and then document it. So yes, we definitely do a lot of reporting. In our clinic, unfortunately, we do. And there's the online system helps a lot too. That makes it so you're not sitting on the phone forever. That helps that you can go into the people who've gone into the portal and done the reporting online.
Yes.
Yes. Okay. Perfect. All right. Trauma. This shows up a lot in primary care. So you have the PCL5. If you want to pull that out. And it has criterion A too, the DSM-5 criteria for PTSD. I think it's 2 pages because I might have stapled the PTSD for primary care screening tool to it.
Oh, okay, yeah.
Yes, perfect. So it should all be together. Fantastic. So screening for trauma. So this is our main option. So if there used to be the PCL-M and PCL-C. This was with DSM-4 TR criteria, one for the military and one for civilians. Then when the DSM-5 came out, they just put it all together. And so there's the PCL-5, which is the 20 items. So it's shorter, which is nice. And it essentially gets at all the main areas that hit on the diagnosis of PTSD. So if you take a look at the PCL-5, if you look at questions 1 through 5, what is that looking at? What symptom of PTSD? We're going to brush up on your diagnosing skills here. Flashbacks, perfect. Questions 6 and 7. What is that getting at with PTSD? The avoidance, yes, that's key. That very much needs to be there. Question 8 through 14. Yes, that negative affectivity, the distrust that patients have. And then 15 through 20. Hypervigilance, somebody said it, hypervigilance, yes. Okay, so I like to use this tool for 2 things. One, it lets me know whether this person possibly have PTSD or not. Do I need to ask some follow-up questions to confirm this or not? Two, I use it as education for the patients. So I actually walk through, so especially someone who we confirm does have PTSD. I'll ask them, has anybody told you what PTSD is? Most of the time, no, I don't know what that is. I just hear about it happens in the military is what they tell me. So I said, well, anybody can develop this after a really stressful situation that they've happened to themselves or they've witnessed. And then I'll go through the symptoms in terms of the re-experiencing, the avoidance symptoms. And patients I found really like that. They said, wow, I didn't know that's what PTSD meant. I didn't know that all these years of what's been happening to me, I didn't know that that's why. So this can be a really powerful tool for you just to do psycho-ed for patients to understand what is going on with them. And they may be more open to treatment once they know that what's happening to them is not their fault. It's not their fault at all. So you have this, and then you have the PCPTSD. So that's the 4-item one. I think it's on the back or the front. Fantastic. I think I have a picture of it. Yes. So if you're strapped on time, which you may be in primary care, you can give the shorter one first. And if they say yes to at least 3 items, then you can give the PCL5. So that's another option too. Especially if PCPs think, oh yeah, this person went through a horrible thing, they must have PTSD. Well, that's not how that works. Not everybody who goes through traumatic thing develops PTSD. So sometimes if they say that, I'll just give the 4 first, just to see what they say. And a lot of times the patients are like, no, I don't have symptoms. I've dealt with that already, or I've been in treatment already. It's not a problem for me anymore. So sometimes I'll give this first if I'm not quite sure. But if I've read through the chart and I'm like, the symptoms really sound like it may be, I'll just go ahead and give them the PCL5. It takes about 5-ish minutes, 5-7 minutes. Because if you look at the first page, you can actually have them write out what was the event that happened. How long ago was your life threatened during it? Did it happen to you, or did you witness this event happening? So for me, this really helps me have a really firm idea if they may have it or not in a short visit, essentially. Any questions about PCL5? And for this, it's in your behavioral screening sheet. The cutoff is typically a 30 or higher. That's an increased likelihood of having PTSD. It's not a firm diagnosis. Remember, it's a screening tool. Okay. All right, watching my clock here. Let's see. All right. So domestic violence, the one that's used the most often, again, play on words here, but it works. Hits, hurt, insulted, threatened with harm, and screamed. So this is a pretty solid tool at seeing if someone's at risk for being in a domestic violence situation. Some health systems screen for this already. And if you're in if you come to University Health System downtown, if that's the clinic that you're in, every patient is screened for DV at every single visit. That's hospital-wide. Doesn't matter. Child, adolescent, an adult, everybody's screened every single time because we have such a high rate of that in Bexar County. So this is what it looks like. I don't think I included it, so I have a picture here. How often does your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you? And so it's quick, it's short. If you're at a clinic who doesn't screen for this and you suspect someone is in a situation like this, you can give this to them, preferably if they're alone in the visit. The biggest thing what I see people do, which is not super good, is screening for domestic violence when their partner, who could be the abuser, is sitting next to them. And so be careful with that. So if you suspect it, you could ask the other person, is it okay if I speak with your loved one and have you step in the waiting room for a few minutes? However you like to do that, but just make sure that they're not in the room when you ask this. or give the sheet to them and leave the room. Their partner's looking at it and like, we're not filling that out. We're not doing this today. And then screening for children. So I want to go over some with you. These aren't in here because you have to pay for these. So these are not in here. The peds. If you're in a pediatrics clinic, a lot of pediatricians use this already for developmental and behavioral screenings. This is great for itty bitties all the way to 9-year-olds. And essentially it's having the parents basically identify if there are any behavioral or developmental concerns that they may have for their child. And then the MChat. Did anyone use the MChat? I think this is actually public domain. So this is completed by the parent if they suspect an ASD for their child. And so this is useful for 16 to 48 months. It's funny why they say 48 months. 4-year-olds instead. So you can use this for young kiddos. Again, the parent completes this. And then there is a score sheet that comes with it that you go over the scores with the parent and then figure out, do they need to see a specialist? Do they need to see a developmental pediatrician? Do they need to see a behavioral analyst? You can kind of see where they need to go for further treatment for that. Ages and stages is like the peds, except for it's just a little bit longer. The full one, there is a piece of it that just focuses on the behavioral, social, emotional impact on children. And so this one takes a little bit less time to do. And so again, the PEDS or the ASQ, they essentially measure the same thing. It's just a preference of offices. I wanted to show you this just in case you say, well, this clinic's using the ASQ 3, but the other clinic my colleague is in, they're using the PEDS. Is one better than the other? They essentially are both pretty good. The ASQ has higher sensitivity and specificity, now that you know what that means. That's a good thing. But essentially they're both very good. I've been in clinics that use the PEDS. In our clinic we use ages and stages questionnaire, so they're both pretty good. Now this one you do have, if you want to find the pediatric symptom checklist, there's a parent version and then a youth version, if you flip it, on the other side. So this tool is really, really nice because it looks at behavioral symptoms in children and adolescents from an internalizing versus an externalizing perspective. So what are internalizing symptoms for a child? What could that translate to in terms of possible diagnoses? Internalizing. Say it again? Mood disorders. Yeah, mood disorders, anxiety disorders, for sure. And then externalizing behaviors in children are usually what? Okay, what's the one that's super common in children? ADHD, that's a common one. Conduct disorder, although that's not a fun one. ODD, maybe that's another one that you see a lot. And then there's the new mood dysregulation disorder that they're using instead of giving kiddos the bipolar diagnosis, so that's another one too. So it's nice because it parses out internalizing versus externalizing behaviors for you as a clinician, so you know where to target your treatment for the child. So it screens ages 4 to 16, so it's a broad range. The youth version that you have, so the one that fills up the whole page, 11 to 18, they can fill that out on their own. And then a 10 to 4, typically mom, dad, guardian, whoever the guardian is, can fill that out. And then the craft I didn't include here. I talked about the PHQA already. But the craft is here, and it's like the audit or the DAS, but for adolescents. So it's a substance use screening tool for adolescents here. This is just a partial part of it. There's part A and part B. Part B asks about like risky behaviors, like have you ridden in a car with another teenager who's under the influence of alcohol? Yes or no, is what it does. So in the past 12 months, did you drink any alcohol more than a few sips? Smoke any marijuana? Use anything else to get high? Yes or no? And so there, you can give this to them you can give this to them face to face if you like. If you want to leave it in the room, you can, but I think it helps, especially adolescents. A little bit harder to build rapport with some adolescents than others. So you may want to give it to them face to face so they can get to know you when you're in the room with them. This is also public domain, so it's free. Multiple languages as well. Oh, I do have it in there. I forgot. I'll just read one of them, so I know we're short on time here. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? And then have you ever gotten into trouble while you were using alcohol or drugs? Moving quickly. I'm going to keep. There we go. Then cognitive screens. How many of you have done cognitive screens for older adults with possible memory impairment or younger adults with memory impairment? Okay, so this will be some new territory for some folks. So cognitive issues come up a lot in primary care. Not always young people, older adults. There's a lot of young folks that come in. They've had a head injury, they've been hit in the head, they're having trouble remembering things. A lot of adolescents, like sports injuries, and so you may be asked to do some brief cognitive screens for them. And then pseudodementia. What's pseudodementia? What happens? You'll probably see this the most in primary care, pseudodementia. Anyone guess? I know people are like, "Ooh, it's 4 o'clock. We're trying to stay awake." You can do this. You guys can do this.
Like symptoms, but it's not a
Okay, you're getting there. What do you think? Remember this term, pseudodementia? No? We've talked about this. Okay, they're like, we're not speaking. She's gonna call us out. So these are folks with major depression who report difficulties remembering things. They think, I can't remember, my memory's getting worse, I think something's wrong, I think I have early onset dementia. We find out, no, you're depressed, and it's a symptom of that. So we call it pseudodementia. So you'll probably see that the most, where providers will say, well, let's screen you first, then we're going to treat the depression with behavioral, maybe medicine, maybe not. They're counting on you to do the treatment. And then come back in 6 months, we're going to screen them again and see if it gets better. A lot of times when the depression's treated, it gets better, or it goes away completely. So you'll see that a lot. So these are some tools that you can use to screen for cognitive impairment. The most common one is called the Montreal Cognitive Assessment, or the MoCA for short. This is really good to give to folks younger than 65. So all those adults that come in with pseudodementia, that they think something's super, super wrong with their memory, the MoCA is really good for them. I also use this sometimes when we have adults who come in with, I think I have ADHD. I need a stimulant. I have ADHD. And then maybe they really do. They just were not diagnosed before the age of 12 for whatever reason. Maybe they do. Doing a cognitive screen like the MoCA is really useful because the number one thing it measures is executive functioning. What is executive functioning? It might be kind of quiet for some of you right now. Your executive functioning skills might be.
They're hidden up back of
Impulse
it.
control, your ability to make deductions and reasoning and
Yes,
rational sequencing.
exactly. Planning, organization, those types. ADHD is a disorder of executive functioning. That is the core of what it is. So sometimes if they may come to you and say, I don't know if this person actually has ADHD, or maybe they're just really depressed and that's what's causing their concentration issues. So you can screen them with that. You can do your visit as you would, but then you can throw that in and just see, they scored a 30 out of 30. So it probably isn't that. It's probably something else that we're missing. So that's a good one to use. The MMSE is used the most for older adults. It's really good for ruling in or out the possibility of developing some type of dementia. So if you work with older folks, which a lot of you probably will, and depending on your clinic, the MMSE is, if you Google MMSE, it'll come up. It's public domain. It's been used for eons. And it's really easy to give. All of these are really straightforward to give patients and take anywhere from 7 to 10 minutes to give. If it takes longer than that, there's probably a good sign there's some impairment if it's taking them longer than 7 to 10 minutes for you to administer this. The mini cog is even shorter. I think it's 3 minutes. It's super, super short. And this is useful for detecting cognitive impairment in older adults. Essentially, it has a 3-item recall where you say 3 words at the beginning, give them the clock drawing test where they have to set the time at like 10 past 11 or something like that. So they'll do their clock and put the time in, and then you'll ask them, remember those 3 words that I told you at the beginning? Can you tell me those words again? That's the test. It's pretty short. It's pretty straightforward to do. So if you're really, 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 really short on time, you could use the mini-cog. This one is also free, and you get a lot of information from this. So you can tell in terms of if someone has some type of frontal lobe impairment or issues with executive functioning, their clock's going to be, all of the numbers might be all bunched up in the corner, or they set the clock wrong. So you can pick up on a lot of cognitive issues just by how they design their clock for you. So the last one here is the slums. It's kind of like the MoCA, except for it's most useful for older adults. So these are all public domain tools. The MoCA is in like 30 languages. There's a lot of languages there. And so I'm showing this to you so that you see that you have a lot of tools at your reach that you can use. If you're in a clinic and you're like, I'm not quite sure where the heck to start with this person, screen them first and then see if that gives you some idea of what's going on. Especially if you're going to do this wonderful treatment for depression and then someone scores a 10 on the MoCA. Everything you teach them, they're not going to remember anything. So we need to pause and figure out what we're going to do differently, because that's probably not going to work well. Yes?
So this severe dementia, that's like any age person can have that?
Which one? Pseudo?
Yeah,
Mhm.
that one.
Yeah. You'll see that a lot in like late 30s to like mid 50s. You'll see that like it's a big range. But if you treat folks, especially with moderate to moderate severe depression, that's one of the big complaints. They have trouble remembering. They can't remember their kids' names. They put their keys somewhere and they can't find their keys. So small things. It's not to the point where I go to Sam's Club and I can't find my way back home. That's a bigger problem if they don't remember the directions home. But little things like I misplaced my keys, or I forgot, I keep forgetting to do this thing at work. That could be a sign of just depression.
Related, then?
Say that again?
It's always depression related?
Possibly. It could be, maybe they're using substances and not telling us. So there could be some other things too, but a lot of times pseudodementia is related to, most of the time, to major depression not being treated appropriately. So, or undertreated. Maybe they're just on an antidepressant. Yes.
Some with anxiety as well, like
Sure.
just being so worried and worried about all the stressors that they got going on, that they're not paying attention to the things around them, or being present or mindful, and so they end up finding themselves like either just being more clumsy or forgetting to look at their keys or whatever, and they'll attribute it to some type of cognitive impairment.
All right, good questions. All right, and then this is in your packet. So adult ADHD, that is alive and well in primary care. You'll see a lot of that happen. So there are some screening tools that you can use. The first one, the adult ADHD self-report screener, that's pretty good. I know it says DSM-4-TR. It's still useful for DSM-5 criteria too. And so that might help you if you don't want to do the MoCA. I still recommend possibly doing the MoCA if their PCP is really pushing. Do we give them a stimulant or not? You may want to give them the MoCA. But if not, screen them for depression and anxiety first, because that's usually the culprit for adults, more so than anything else. But again, a lot of adults, again, are not treated in childhood, or it's missed, unfortunately. And then the Wender, I didn't include this because it's public domain. The biggest thing I have with the Wender is that it's retrospective. So, could you tell me how you were at 7 years old? Okay. Could you tell me how you were at 7 or 8 years old? So, expecting the patients to tell us Yeah, she's like, perfect. I did everything perfect. So expecting our patients to tell us that, it's pretty hard to do. If they have family members that can give collateral support about how they were as children, or if they can get school records from 20, 30 years ago, that's fantastic. But most people cannot do that. So I don't use this one as much just because I find patients are like, they'll come back and say, I don't remember how I was, I'm not going to fill this out. So I don't give that one as much to folks anymore. But I want to let you know that it's there, just in case it comes up in a conversation with your providers. Okay, and then last but not least, not last, we have one more before last. This is a quality of life. One of the things that I think we tend to miss sometimes is that we're so focused on symptom management that we forget about what are we doing to improve the overall quality of life of the patient. And so for me, if their PHQ-9 is a 15, but they have a job, and they have family, and they have friends, and they're exercising, and they feel that I'm doing pretty good, I like this, I'm good. I don't need to see them until their PHQ is a 0. It may not ever get to a 0. It doesn't need to be at a 0. And so quality of life tools are really nice because it really helps you focus on how are you doing with friends? Are you talking to your family members? Are you exercising? Are you eating okay? How is your sleep? It's all these other things that really go into play to show you as a person really functioning well or not in their lives. So these are some examples of ones that are almost free, except for the SF-36. You do have to pay for that, but these other ones are free. And then I have an example of the CDC measure, the Core Healthy Days measure. I'll just read the first one. Would you say that in general your health is excellent, very good, good, fair, or poor? And so patients can usually have a good idea how they think they're doing or not doing so well. And then sleep, this is in your packets. Who's treated insomnia before? Anyone treat insomnia? Okay, you will soon. You will soon. So the Insomnia Severity Index, you have it there. It's a short, it's one pager, it's pretty brief. And it's a nice way to measure someone's level of clinical, if they have clinical insomnia or not. There are specific interventions for insomnia that you will learn very soon. In the past 12 months, CBT for insomnia, cognitive behavioral therapy for insomnia, has now become first-line treatment for clinical insomnia. So it's no longer take this trazodone and go away for 5 weeks. We need to do CBTI first before we do anything else. There's a problem with that. I have providers in the community come tell me, I can't find a therapist who knows how to do CBTI. Why are they going to make these guidelines, but I can't find anybody to do that? So like, I'm just going to keep prescribing meds because I can't find help to do that. So you all will be trained on how to do this so you can help this. It's really straightforward to do. It's really brief. But to measure insomnia, this is one way that you can do it to give you an idea of how much it's impacting the patient's life. And then last but not least, if you flip that sheet over, eating disorders aren't super prevalent, period. They're not prevalent, period, in the psychiatric world. But they're not super prevalent in primary care, but it does happen. We've treated some eating disorders in our clinic too. All age ranges. Adolescents, I've treated adults. That's still, this is a longitudinal issue. This doesn't go away for a lot of folks. And so the SCOFF and the ESP are two really brief tools. If you suspect someone that you're treating may have an eating disorder in your clinic, you can give them one of these tools. Now the key with the SCOFF, this was developed in England. So you have, in terms of a stone, have you lost a stone in the past? I think it's 13 or 14 pounds. I think it's 14 pounds. Before, when I gave this to a patient years ago, and I didn't look at that before I gave them, they were like, what is this? What is this stone? I'm like, sorry, it's 14 pounds. 14 pounds. And then you have the ESP there, so you can take a look at those there. So again, I know this was rapid fire, Again, you can ask questions at the break. I'm happy to answer them, but I really just want you to know that you have options available to you in your clinic. So you'll probably use the PHQ and GAD-7 most often in your practice, but know that you have other things that you can use too, especially the quality of life tools. Yes, ma'am.
Since these are self-reporting tools, I mean, I'm assuming that there can be some shame involved with some of these conditions.
Sure.
And so what if, like, they report and they're not reporting honestly, but you still suspect, like, what measures do you take after that?
You can have the conversation about it, but ultimately it's their choice. You know, they don't want to deal with it right now. That's their choice. There's a lot of people underreport all the time, or over-report to let you know that I really need help. So they really want you to know that they need help. So you always follow up the screeners with a conversation about, I see that you scored this. This is what the scores mean. Especially if someone screens very low, but I still think there's something there. I may say, I understand that your scores were low. I'm still here to help you. If you still like some help, we can definitely do this in the clinic. So I still offer it, even if their PHQ is a 0. And I still think that we could be of some use to the patient. I'll still offer, would you still like a visit today? I know your score was 0, but we can still do the visit. Yeah, and most of the time, they'll say, yeah, I would like a visit. Yes.
I think about how word my question. How much do you say that we can expect for these screening tools to already be being used in these sites versus things that we will be
Like introducing, sure.
And if it is something that's being introduced, could you speak to sort of the process for that? Like,
Sure.
you know, making sure it's okay, how would it appear in notes?
Sure, absolutely. So majority of the sites will at least be using the PHQ-9 for sure. The other tools they may not be as familiar with or using. Women's Health uses the postnatal one. I know they use that. Though whoever goes to that clinic. If you're using a screening tool that's not there, that's fine. As long as you can back it up with your expertise. You use whatever you feel is necessary. All of these things have evidence for primary care. So you can use any one of these things in saying, I think this is clinically indicated to use this with the patient. You'll just document in the objective section of your note, just right underneath that, I gave the DAS, patient received a score of that, and this is what it means. Really brief, just so they know that you gave it, and that we have a way to track it if they don't have a mechanism to track it formally already. So some of the clinics will, but some won't. And so that's kind of the way to get around that you can just free text it in your document that you gave this, and this is what the score was and what it means. And it's a great way to do lunch and learns at your sites, to do some provider education. You could have a screening tool of the month, if you'd like, to introduce them to, if you see the DAST in my note, this is what it means, and this is what I screen it for. They will welcome that, because they don't know a lot of these things. And so anything new that you can bring to the table to help them practice better is a good thing. So however you'd like to introduce it to them is fantastic. So let's take a short break.